All right, thanks. So good morning, everyone. Welcome to Sleep Medicine Going Rounds. And today we've got Dr. Kamal, Gandotra, who everybody knows well, from the VA and the site director for the Sleep Medicine Fellowship Program. And he is going to be taking us through a tour of psychotropics and sleep.
Yeah, thanks for inviting me, everyone. So, as Shashil said, the topic which I'm going to be discussing is psychotropics and sleep. Okay, so in reference to the objectives, hopefully by the end of the presentation, everyone will be able to differentiate between frequently prescribed activating and sedating psychotropics. Next, be able to identify associations between psychotropics and sleep pathologies. And lastly, describe the mechanism of action of commonly prescribed psychotropics. On a personal note, I want to say that this is a very high yield topic. We all know that there's a bi-directional relationship with sleep disorders and mental health conditions. We all know that sleep apnea is associated with depression, insomnia is significantly associated with depression. And it's good that we have this on our radar. You know, in the VA and at UH, when patients come in with mental health conditions, we screen for comorbid sleep conditions and vice versa. But it's really important to know about the psychotropics, because sometimes just adjusting the psychotropics, either the frequency or the dose, can improve the sleep pathologies, and I'll get into that a little bit more. I orchestrated this presentation via cases this time, so it can be a little bit more interactive. I do want to preface this by saying these are real cases that I've seen in the fellow sleep clinic or in my mental health clinic. I'll go ahead and read the first one. A 36-year-old female was referred to the sleep clinic for her restless leg syndrome. She reports her psychiatrist noted that her RLS is preventing her from sitting still. She reports, I always feel nervous and I can't relax. I feel like I have this uncontrollable need to move. During the evaluation at 3 p.m., the sleep provider noticed her crossing and uncrossing her legs repetitively and swinging her legs while sitting. While standing, the patient shifted one foot to the other repeatedly and occasionally marched in place. She reported no circadian component to her symptoms and noted movement does not decrease her symptom intensity. What is the next step in management? Kate, you made eye contact with me first.
I would D.
D, good. So that's the correct answer. Inquire if a new medication was started or if its dose was increased. This in fact is not RLS. This is a condition called akathisia. Akathisia is a condition in psychiatry where a person has a inner sensation of restlessness. And it's hard to differentiate between RLS because sometimes there's some overlapping features. But if you notice in the question stem, there was no circadian component. When we think of RLS, you know, usually the first thing I ask a patient is, do you have an urge to move? And if they say, no, I don't have an urge to move, I'm not thinking of RLS, I'm thinking of peripheral neuropathy, peripheral vascular disease, spinal cerebellar degeneration. But if they say, I have an urge to move, then I'll say, well, when is your urge to move? They'll say usually at night. Even in cases of RLS where patients say, doc, I have symptoms all day, historically, at some point, they're gonna say their symptoms started at night. So in this condition, this person's condition, there was no circadian component. And in RLS, it's usually relieved by movement, the symptoms. So here in this case, the person, their symptoms did not decrease with movement. So with akathisia, it's a very serious condition because it's at the point sometimes where patients even feel suicidal, it's so bad. And a lot of times, these are classic symptoms in the question stem, where the person swings their legs back and forth, they cross their legs repetitively. When I was in my office seeing this patient, the patient was constantly going like this and marching. And I said, well, what are you doing? She's like, I just can't sit still. And lo and behold, I realized that someone had put her on aripiprazole about 2 weeks ago. Generally, any medication that's a dopamine antagonist will cause akathisia. It doesn't have to be an antipsychotic. It could even be something like metoclopramide, which is used for nausea and vomiting because that's a dopamine antagonist. But the key hallmark features here are that it doesn't get better with movement and there's no circadian component to it. Other ways to delineate between the two is that patients with akathisia don't typically have that paresthesia that RLS patients have. They don't have that prickling in their legs or that tingling in their legs. And it's not really related to sleep. This is actually a helpful chart that I use because since lying down somewhat helps with akathisia, there's usually not a sleep disturbance. Whereas in RLS patients, it's worse at night and their sleep latency is probably going to be prolonged because of their RLS. With akathisia, luckily, if you stop the medication that's causing it, it usually goes away within 2 weeks. I stopped the aripiprazole and then within 2 weeks, she was fine. Akathisia is more caused by an imbalance of norepinephrine and dopamine. So that's why we use beta blockers very often, like propranolol, because propranolol has, it blocks those noradrenergic beta receptors.
I want to ask you a question here.
Of course.
If you're seeing someone and they have a psychiatrist, but you don't know, what do you do when you sort of say to the psychiatrist, this is an RLS? How do you say you've got the medication and you could just say it's not RLS there? Is that received very well most of the time?
So usually, well, in the VA, what I'll do is I'll just tag the psychiatrist on the CPRS note, and I will Teams them and call them and explain to them that this is an RLS. Usually it's received favorably.
Okay.
I haven't had any pushback. But this is where, you know, there's a big link between sleep and psychiatry, and then that doctor to doctor communication is really important. Do I have a volunteer for question 2?
56-year-old male presents to the sleep clinic with complaints of insomnia and daytime hypersomnolence for the past 2 months. He reports, I sleep all day and stay up all night. He reports being unable to stay awake during the day with frequent episodes of unintentional daytime napping. At work, the scale is 22. He reports taking lisinopril 10 milligrams daily for hypertension, as well as olanzapine 10 milligrams by mouth for schizophrenia. He reports lower doses of lisinopril and olanzapine do not resolve his hypertension and psychosis, respectively. He reports starting both medications about 8 weeks ago. After completing a comprehensive history, there is a low pretest probability for sleep apnea or narcolepsy. What is the next best step in addressing his nocturnal sleep fragmentation and excessive daytime sleepiness? I think I would look at B. Olanzapine can make you sleepy during the day. He was taking 10 BID. I think I would go with E to take it at night.
No, really, really good. Yeah, that's the answer. Olanzapine actually is one of the most sedating psychotropic medications, second to clozapine. I can't tell you the number of times I've seen in sleep clinic, the patient's taking olanzapine 10 milligrams twice a day, and then sometimes providers will order like a PSG MSLT, and they'll have a low sleep latency, or a mean sleep latency on the MSLT like 3. So it's really drug-induced hypersomnolence. Olanzapine, the peak blood levels occur within 6 hours after taking a single dose, and the effects are long lasting. And it's a very sedating med. The half-life is about 36 hours. I remember when I was in residency a long time ago, I was in VCU, and essentially we had a big team, and the pharmacist asked me if we could. A patient was taking olanzapine 10 milligrams twice a day. She said, could we consolidate it at night? And I said, well, why? She said, well, the half-life is 36 hours and it'll cover his psychosis all throughout the next day, and it'll be easier for the patient to take just one dose. Olanzapine is never given in divided doses, even though we see it given in divided doses all the time. But from a sleep perspective, olanzapine is extremely sedating, strongly antihistaminergic. So, the biggest risk factor for psychosis is sleep deprivation. So giving this to the patient at night would be a good idea. And most patients with schizophrenia have polyphasic sleep pattern where they're intentionally, the biggest impairment in schizophrenia is social impairment. And they generally like to sleep during the day and be awake at night, so they're not around people. And this actually helps with that social impairment. You regulate their sleep-wake cycle so they can come to their appointments. So, the take-home message is to always give olanzapine in a single dose at night, regardless if it's for schizophrenia or bipolar disorder. And then coming back to this, adding zolpidem or trazodone might lead to some next day residual sedation. Generally speaking, we never do sleep restriction for anyone with schizophrenia because sleep restriction can lead to psychosis. And in reference to the Adderall, if in a rare case where you consolidate the olanzapine at night and hypothetically the person still has this next day residual sedation, you would try to move to a less sedating antipsychotic before adding Adderall, because Adderall is also a stimulant and could lead to stimulant-induced psychosis. If you got to a point where you were exhausted and you had to give a medication to help the person stay awake, you would probably go with bupropion because that has some stimulatory effects, but not Adderall because that's like bupropion and steroids. But usually with these patients, the main thing is that when they're taking olanzapine twice during the day, they end up sleeping all day, possibly decreasing their homeostatic sleep drive and adenosine buildup. This is a chart that's just looking at the antihistaminergic potential. So you can see that out of all the psychotropics, olanzapine is the strongest antihistamine. It's a very, very sedating medication.
Is
Sorry,
it
go ahead.
still prescribed quite a bit?
All the time. All the time.
I don't see that as much as.
So in the inpatient unit, we use it quite a bit just because it's a very potent antipsychotic. I was one time very, very, very surprised when I wanted to convert Haldol to olanzapine, because Haldol is a first generation antipsychotic, and you would expect that when that blocks dopamine, that stays on the receptor, whereas olanzapine tends to dissociate. But olanzapine still required a lower dose. It's a very high potency antipsychotic. So it's used very well for cases of refractory schizophrenia. So to answer your question, it's prescribed quite often. Good question. Any takers on question 3?
23-year-old male presents to your office complaints that's daytime sedation, which started a few months prior. He reports, I feel like I'm fighting sleep during the day. Is that worth 16? His recent in-lab sleep study showed AHI of 2, RDI of 1.9 with normal saturation independent of respiratory events and total sleep time 6.5 hours with 60 minutes of total REM. Learned denies cataplexy episodes, sleep paralysis, nor hypopneic or hallucinations. He reports his excessive daytime sleepiness started 3 months ago. On identification reconciliation, he's currently taking amitriptyline 50 milligrams twice a day for depression and Motrin 200 milligrams occasionally for back pain. What is the next step in management to address his hypersomnolence? Last question. That's all I need. Stay medication at night.
Let me go through each of them.
So one is to order phase 3 MSLT to evaluate. Probably an option on current medication as well as recency of symptoms. Repeating his in-lab PSG is otherwise no changes. Sleep disorder patterns. Organic causes. Motion, quality.
Probably been rats and high doses of produces. It's brain, cytokine,
Oh,
we're trying. So D is bigger.
yeah, so glad to see that the fellows know these very well, and D is the answer. It's the same principle with olanzapine. Amitriptyline is very sedating for different reasons. It's more anticholinergic than antihistaminergic, but it is both. The half-life is about 25 hours. So, I mean, we see amitriptyline a lot, whether it's for depression or migraine headaches. Repeating, sometimes people want to repeat an in-lab PSG. According to the ASM, when they compared a single night in-lab PSG versus 2 consecutive nights, there was no significant difference in the AHI. So I know with a home sleep study, if it's negative and we still suspect sleep apnea, there's a knee-jerk reflex to do an in-lab study. But if you get a good, decent in-lab study, you don't need to repeat it. And of course, ordering a PSG MSLT, you would actually want to remove amitriptyline 2 weeks before doing that. This is a KI constant chart, and with a KI constant chart, the lower the number, the higher the affinity to that particular receptor. So if you look at the third column where it says H1, that's histamine, and a high number indicates that there's not that much affinity to the receptor, and a high number would be anything that's 50 or above. So if you look at amitriptyline, you can see that the number is 1. So it's a very low number. So it's very antihistaminergic. And if you go to the muscarinic column where it's for acetylcholine receptors, it's 18. So it's very anticholinergic and very antihistaminergic. And if you go to the second column for amitriptyline, the NA, the noradrenergic, it's 50. So it doesn't have that much affinity to the norepinephrine receptor. So it doesn't really release norepinephrine. So it's a very sedating med. We can do another one for fun, like the last one, which is desipramine. If you just look at the second column, the number is very low. It's 0.83 to the noradrenergic receptor. So it releases a lot of norepinephrine. It's a very activating medication. And then its histamine number, the H1 is 110. So it's not really that antihistaminergic. So if someone was taking desipramine, they would take it in the morning. Whereas if someone was taking amitriptyline, they would take it at night. Any takers?
All right. 35-year-old male presents to sleep clinic with cheek complaint, insomnia, reports difficulties falling asleep in the past month. Sleep latency has increased from about 20 minutes to over 90 minutes. He reports making some lifestyle changes. He reports I lost 5 pounds in the last few weeks. I even quit smoking to improve my health and sleep. Doctor prescribing appropriate last month, which I take with my dinner. Decrease the number of cigarettes I smoke from 2 in the morning. What's the next best step in management of his sleep onset insomnia. So, bupropion is pretty activating, so that's one I keep in my back pocket and say, that's gonna take bupropion 30 minutes before bedtime. Trazodone nightly. These two drugs, I think so one drug is standard problem. And refer to cognitive behavioral therapy for insomnia. I'll take ordered in-lab sleep study. I don't think that'll help you because it doesn't give any indications of people instead of. I think it's gonna be A.
Yeah.
As a norepinephrine.
Right, that's exactly right. I can't tell you the number of times in sleep clinic and in psychiatry, I see someone come in for insomnia. And their insomnia started about a month ago and they were put on bupropion a few weeks ago and the prescriber gave it at night. It's a complex problem, simple solution. You won't escape seeing this. Bupropion, you know, it's when I see it on somebody's medication list, it has a lot of indications. It's used for major depressive disorder, seasonal affective disorder, ancillary therapy for ADHD, weight loss. It helps people maintain sobriety from cocaine. The SR formulation is used for tobacco cessation. I wanted to talk a little bit about the different formulations of bupropion, because knowing that it's just activating it isn't enough. This is one of my favorite medications because it doesn't work on serotonin. So bupropion will not cause restless leg syndrome. It will not cause periodic limb movement disorder. It will not cause REM sleep behavioral disorder. So, you know, from a sleep perspective, I like it in that sense. The one thing to keep in mind is that it's very activating. There's 3 different formulations of bupropion: the immediate release, the sustained release, and the long-acting release. All formulations are activating, but I generally like the long-acting, the best one. The Cmax is the highest concentration in the plasma when the drug's at its peak blood level. And the Tmax is the time that it takes to get to the Cmax. And these are based on 300 milligram models. So initially, when they only had the immediate release available, you would take 100 milligrams 3 times a day. So and you would have to take each dose 4 hours apart. And the Tmax is about 2 hours to reach the Cmax. So if you give it at 8, it'll peak at 10. You give it at 12, it'll peak at 4 p.m. You give it at 4 p.m., it peaks at 6 p.m. That's not good because the person is having that noradrenergic focus in their bloodstream. They're activated in the evening. It's a very hard medication to dose. I mean, unless someone's working 3rd shift and they're sleeping during the day and they start their first dose at like 8 p.m. and they're working throughout the night, I would never recommend that one. The SR formulation, the Tmax is 3 hours, but it comes in 150. So you would, if you take it at 8 a.m., it would peak at 11 a.m. And then when you take it at 12, it peaks at 3. So that's a lot better. So it would be low, it would have a lower plasma level in the evening. The XR formulation, the long acting, is my favorite one because it's one single dose of 300 and the Tmax is 5 hours. So if you take it at 8 in the morning, it peaks at 1 and then it could be very low in the evening and less likely to interfere with your sleep. So when I see someone coming in and they're taking bupropion, if they're on the immediate release and they're taking it 100 milligrams 3 times a day, I'll try to switch them to the XR formulation or tag their psychiatrist or primary care doctor to consider switching it to the long acting. You know, I also want to say that it's a good medication that, you know, can be used for other things also. I have a narcolepsy patient, which he had stimulant-induced psychosis, and I have him on armodafinil, and I'm maxed out on the armodafinil, so I'm supplementing the bupropion SR formulation, and it's helping him a lot. So you can use it for other things too, from a clinical posture.
Is there any adverse effects
of bupropion.
Differences between the formulations, or they all have the same sort?
Very good question. I presume that they have the same side effects. They don't work on serotonin, so there will be less diarrhea and constipation, more restless, more noradrenergic focus, restlessness, irritability, anxiety, insomnia, and tremors. I would assume that the IR has maybe more because it's peaking, but I'd have to get back to you on that. Good question.
These 3 times, right?
Yeah. Good question. What do you think, Kate?
34-year-old female presents to sleep clinic reporting for the past 3 months. I keep kicking in my sleep. My boyfriend says I kick him while I am asleep. I'm not aware of it. Occasionally it wakes me up. When I sleep alone, I find my bed sheets hanging off the side of the bed, if not on the floor. She reports being tired during the day, possibly because of her limb movements. A sleep study was ordered by her psychiatrist, which indicates sleep apnea is not present. However, her periodic limb movement index is 27 per hour. She's given a diagnosis of periodic limb movement disorder, given both her objective and subjective findings. She reports starting a venlafaxine a few months ago and reports her severe depression is finally under control. What's the next best step? Wow. Need to take her off the venlafaxine if she's doing well on it, but if she can be switched to bupropion.
Let's go through it. 1, 2, 8, 10 ferritin level.
Uh,
Had to have one, that's a good idea.
yeah.
B,
She's doing well on the venlafaxine, so don't want to do it. Maybe start a gabapentin. If we haven't rolled up the low ferritin, then I'd rather treat it low iron than give a metformin. And then the same with D&E.
Yeah, no, I'm kind of laughing inwardly because I gave this talk to a group of, my wife's a primary care doctor and her friends, and everybody had a problem with this question. So, probably there's 2 answers. I mean, I think, obtaining a ferritin level is definitely reasonable. For the answer choice that I had put was letter B, just because, venlafaxine is notorious for causing periodic limb movement disorder. So probably there's 2 answers to this question. It was on both my sleep boards and my psychiatry boards with the venlafaxine. Usually whenever someone comes in on venlafaxine, I ask them, are your bed sheets crumpled up in the corner of the bed? Are your bed sheets hanging off the bed? Is your partner complaining that you're kicking them? Those kind of things. The odds ratio with venlafaxine, I think it's it's 5 times more likely than controls to have a PLMI greater than 20. One thing I want to mention with this question is that when we think of RLS and PLMD and we think of these psychotropics, we have to be very careful because these SSRIs, only 9% is associated with RLS. So sometimes, in clinic, someone will come up to me and they'll say he has RLS or she has RLS. I want to take them off the Prozac or the bupropion. So it's really important to establish a temporal relationship because a lot of times the RLS or PLMD might have commenced before starting the psychotropic. The key point in this question is that venlafaxine is very much associated with periodic limb movement index.
I mean, to that point, so let's just say you started venlafaxine or any other SSRI sometime in the past. At what point do you sort of say that, yes, it's interesting to run an SSRI, but it's not related?
Yeah, it's very, very hard to tease out, like really taking a comprehensive history. Sometimes it's good to have the person's spouse with them because some of the patients are not, unfortunately, not sophisticated enough to remember when exactly their symptoms started. So it's a very tough situation. If they tell me that the symptoms, if they're able to connect the dots and say, I started Prozac and a few weeks later, I started having these symptoms, then I kind of am able to establish a temporal relationship. But if they say, I'm not really sure when this happened, then you're kind of stuck and you kind of end up, obtaining a ferritin level. And then unfortunately, in some cases, giving a med to treat the side effect of another med because the person doesn't even want to come off of it anyway. So, yeah.
I ask you two things. First is, you had the PSG showing 20. Was that an arousal index or was that just a PLD index? I mean, is it, because we sometimes distinguish that, the arousal index, PLM, the arousals versus those without arousals, or does it matter?
I would have to go back and check with the reference. I'm pretty sure it was with an arousal index. Yeah.
And the second one was, why does it take 2 weeks?
Why does it take 2 weeks?
Yeah.
Oh.
Is it just part of the old saw that any antidepressant takes a long time to work?
Well, so the general rule in psychiatry is 6 months is the perfect time, but 2 years is too long. So with venlafaxine, just a side point, I just want to mention at 150, it starts to work on norepinephrine. So usually if you are using this med or someone else is using this med, keep in mind that doses of 150 or higher have a noradrenergic focus, and it should be given in the morning as opposed to the nighttime.
How about if they're on twice a day?
Twice a day of
Yeah,
venlafaxine.
20 milligrams, fine.
Then it's just, if they're on 25 milligrams twice a day or 37.5 twice a day, sometimes you see that for hot flashes.
Right,
It's just predominantly at a serotonergic focus.
so it wouldn't be
It wouldn't be
it would
activating.
be active.
Yeah. Good question. Sydney?
50-year-old obese female comes into the clinic for follow-up. Upon review for PAP download for greater than 4 hour usage is 90%. Her AHI residual is 1.4. Her leak is insignificant. She reports difficulty with sleep initiation and sleep maintenance, which started 3 weeks ago after a psychiatrist placed her on antidepressant at bedtime. She reports her mood system symptoms have been resolved, but is concerned about her insomnia, which antidepressant would she likely prescribe. Sertraline, paroxetine, fluoxamine, we have more
So this is a tough question. The answer is A, sertraline. Sertraline is generally an activating med. The paroxetine is anticholinergic, so it's sedating. Mirtazapine is very antihistaminergic, and it's not really, it would have been more fair if I would have put the dose there of the mirtazapine. And the Luvox inhibits the degradation of melatonin, so it tends to be sedating. One thing that I want to mention is, let me just move to this slide, is that all SSRIs inhibit the reuptake of serotonin. They all have that primary mechanism of action, but each SSRI has a secondary pharmacological mechanism of action, which makes it unique. Sertraline inhibits the reuptake of dopamine directly, and dopamine is a wake-promoting neurotransmitter, so sertraline tends to be very activating. In fact, we use it in patients who have depression with psychomotor retardation. They feel like a bump on a log, or a stick stuck in the mud, or if they have hypersomnia and fatigue. So sertraline, because it inhibits the reuptake of dopamine, is very activating. However, I do want to mention one thing. People respond differently to meds. Here and there, you come across a case where the person will say, "Doc, I'm taking sertraline, but it's making me sedated." And then I'm thinking, well, maybe I'm not treating his depression enough. This fatigue or sedation is due to his depression. So I'll increase the sertraline to 100. Then he'll come back in a few weeks and say, "Now I'm really tired during the day." Then I say, well, let's take it at night to exploit this side effect and treat the insomnia. I have spoken with a lot of pharmacists about this, because when you look at these brochures for sertraline, essentially it will say insomnia or sedation, and
Yes.
you're pulling your few hairs that you have left, and I'm saying, well, wait a minute, this can't be right. But so essentially what I'm saying is that there's one pharmacist, he's a national guy at the VA, and he conveyed to me that 20% of SSRIs, the ratio is 20% for sertraline, that it can cause sedation. And we probed into this to figure out why, because I've had every 100 times I prescribe this med, I'll get a case where somebody says they find it sedating. The only thing that I could find is that patients who have a polymorphism in their orexin type 2 receptor gene find sertraline sedating. That was the only paper that I came across. So, if I had to bet in Las Vegas, give it during the day, it's most likely going to be activating, but don't be surprised if you see a case where it's sedating.
You should put that into the billion vet. Because they just reported, I didn't realize they just reported their sleep apnea hits. Sure, Dave Gottlieb is the senior person. I don't think he's the geneticist, but that was done by the Estonian genetics group, so contracted out to Estonia. All right, okay, so it must be long. All right,
Hey, Drew, can I call on you?
27-year-old woman comes in with a history of borderline personality disorder. She reports a history of cutting her wrist 4 times in the past year in an effort to end her life. She engages in psychodynamic psychotherapy, but endorses suicidal ideation currently. You decide to start fluoxetine. She agrees. She asks you the most appropriate time to take the medication. By night, 7 p.m., 8 p.m., or at noon, 12 p.m., or 8 a.m. in the morning. My inclination would be in the morning, 8 a.m.
You're right, and actually, I think me and Sydney just had a case of this in Fellows Sleep Clinic last Friday, where we were working together, and he mentioned, can we put the fluoxetine in the morning, because the patient was taking it at night, to help with the insomnia. We just moved to this slide here. Fluoxetine is the most activating SSRI. In reality, it's very activating. Like, I would be very surprised if someone told me they were taking fluoxetine and it was causing them to feel sedated, because its secondary pharmacological mechanism of action is that it inhibits the reuptake of norepinephrine. So it's very, very activating. And when it's postsynaptic receptors, it blocks 5-HT2C, which causes a further release of norepinephrine and dopamine. So it's actually hitting all the neurotransmitters involved in depression. It's a very activating med and should be given in the morning. So if you see it at night, it's something to discuss with their provider.
A 96-year-old male was referred to the sleep clinic for hypersomnolence. Epworth started about 4 months ago. So that's a clue. Medications include amlodipine, 10 milligrams daily, mirtazapine nightly for insomnia, prescribed by mental health provider. And over the years, he complained of insomnia, received different sleeping pills on different days. finally given a dose of mirtazapine 30 minutes before bedtime a few months ago. She reports helped him sleep through the night. Of course, he started mirtazapine. Her husband is somnolent and exhibits next day prolonged sleep inertia. Workup for delirium was non-revealing. Mirtazapine discontinued his sedation. Progressively resolved. Which dose of mirtazapine was the patient most likely to prescribe? So this is the one that is taking at night. Right. So the only reason I remember this is Kamal talking about this, which is that it has dose effects on hitting receptors that make it either activating or sedating. And then 7.5 is very sedating, 15 is less so, 30 is even less so, 45 and 60 not sedating at all. So the guy that is sleeping at night and sleeping during the day, I mean, it's 7.5.
Yeah, that's exactly right. We all have this dogma that the higher the dose, the more sedation and more side effects.
No, it's really a higher dose, the better the depression is managed. I
Right.
think that's the, I
Yeah,
think that's the way people get out there and they don't know sleep medicine, don't know these dose effects.
agree.
That's what
Yeah,
happens. They start off
yeah.
at some point and then keep going. Or split the dose or do something, right?
Yeah, this has been a challenge at the VA. And this was this case that was a case in my mental health clinic. This patient was referred to me and the primary care doctor had put him on 7.5 at night to help him sleep. And he had a PSG that was positive and they wanted me to treat his sleep apnea, but his AHI was 5.4. So I mean, he had sleep apnea by the skin of his teeth. And so I immediately saw the mirtazapine and discontinued it. And after a few weeks, he was fine, during the day. So it's something to keep on your radar. And like Dr. Stroll mentioned, the lower the dose, the more sedating, and the higher the dose, the more activating. It's an antihistamine at all doses, 7.5, 15, 30, 45, and 60 they use in Europe. But the key message is that if you give someone 7.5 at night, expect that 99.9% of the time, they are going to be on autopilot the next day, extremely zoned out and sleepy. 15 is a little bit better, but 30 is generally the dose that I keep, because 30, you start to release norepinephrine. It's still antihistaminergic, but you start to release norepinephrine and that counteracts some of that antihistaminergic effect. So they can sleep at night, but they won't be excessively tired the next day. At 45, you can still give it at night, but keep in mind that there's a subset of the population, about 25%, which will find 45 activating, and you have to give it in the morning. At 60, if someone is going to use that, they have to take it in the morning. There was somebody who accidentally took 60 one time, and they were running around at night like a manic patient because of that big noradrenergic focus. But I do want to mention one thing in my population that I deal with. You can only use mirtazapine at 30 in the context of depression, anxiety, PTSD. It's not FDA approved for sleep. I mean, I sometimes wonder why not, but the more I think about it, if somebody's taking 7.5 at night and they have that next day residual sedation, they could get into a car accident, they can't function. So maybe that's not a good fit. But then when you go to 15, there is one study that says with 15 milligrams at night after 9 days, it didn't impair next day driving performance. But most of the patients from a clinical posture where they say, okay, I'm taking 15, it's helping me sleep. I say, well, let me just put you on 30. I put them on 30 and they like it so much better. And then if you give somebody 30, now you have turned the med into an antidepressant and it's working on serotonin and norepinephrine. They have to take it on a daily basis. And if they stop taking it, they get withdrawal symptoms. So maybe, I don't know that, maybe that's the reason it was never approved for monotherapy for insomnia, because it's not on the list. But that's.
Are you saying, so I was gonna ask you the question, why not just start at 30? But, yeah, that you're using it both as an antidepressant and the fact that you have to take it daily, yeah.
I also thought you made a good point that the person says they can't sleep, you can give them 7.5 and knocks them out for the next day, you say, yeah.
Yeah, that there are some providers that you can use 7.5 as PRN, I guess, technically, because it's an antihistaminergic, but it's not, for other reasons.
I've seen some people on 7.5 that function every day. I mean, you've probably seen 3 of last year
Yeah,
that have come in here on that dose at night. And I kind of shake my head and say, well, what's different about them as well?
yeah, something to unravel. I've seen a few of those cases too. It's hard to believe. I have a volunteer for question 9.
Sure. 45-year-old male presents to the sleep clinic with complaints of insomnia. His medications are lisinopril for hypertension and mirtazapine for sleep difficulty. He reports an increase in difficulty with sleep initiation for the past 6 weeks. He reports seeing a PCP who placed him on mirtazapine 30 minutes before bedtime to help him obtain consolidated sleep about a month and a half ago. He reports no history of depression. He reports, ever since I started mirtazapine, I feel my insomnia has gotten worse. Before I started mirtazapine, it took me an hour to fall asleep. Now with the mirtazapine, it takes me 2 hours to fall asleep. Which dose of mirtazapine was most likely prescribed? It's probably the highest dose.
Yeah, you're right. And it's the same principle that I had mentioned before. The higher the dose, the more activating the medication is.
So what would you do?
So, yeah, what would you do?
Yeah. Talk to the patient for an hour about why you're reducing his antidepressant.
Yes, that actually happens a lot. Sometimes I'll have somebody on 45 milligrams and they can't sleep, and I'll just lower the dose to 30 and it solves the problem. But then you have to have a discussion with who's ever prescribing the med. But, yeah. This is just a slide of mirtazapine. The only thing I just wanted to mention is that at 30 milligrams is when you have these presynaptic alpha-2 receptors on your serotonergic and noradrenergic neurons, and they kind of hold norepinephrine and serotonin above the synapse. Once you block them, it kind of cuts the brake cables, and that's when it starts to release norepinephrine. Can I ask you?
44-year-old male presents to a sleep clinic with complaints of insomnia for the past few months. Veteran reports being actively depressed. He notes, I have tried every medication to cope for my depression, even ECT did not work that well. He's currently taking transcyclopramine 60 milligrams, then 40 milligrams, then sulfone 40 milligrams 30 minutes before bedtime. He reports his ECT has led to memory impairment and that he is unable to recollect when he started these medications. He reports his sleep initiation is over 3 hours at times. He also reports several weekends throughout the night with an ability to return to sleep at times. Epworth is 11, eyesight 17. What's the best next step?
Excuse me for a living. Tranol, Cipramine. Must be for depression. Blues from the day.
Constant insomnia unlikely to be they're evaluated for further diagnostic testing right now. Generally, but give statins at night. want to avoid having medications. Whatever. It's like, yes, seems to have stimulatory effects for this patient, so we can change it to morning.
Yeah, that's a good answer. I've only seen this prescribed twice, you know, but it's,
That's a test question.
yeah, I've only seen it for, it's an MAO inhibitor. In my opinion, they're the best meds for depression. I mean, they came out in the 1950s, 1960s. They block that monoamine oxidase, so you get more norepinephrine, dopamine, and serotonin. I mean, they're very effective. However, because of the side effects and drug-to-drug interactions, we don't prescribe them as much, but really, really good meds. They're all, they're basically all activating because they're all increasing norepinephrine, serotonin, and dopamine. So this one is the most activating because it's structurally related to amphetamines, and it's been shown to prolong sleep latency and increase awakenings throughout the night and cause sleep fragmentation. And out of all the antidepressants, these are the ones that longitudinally suppress REM sleep. And of course, if you abruptly stop them, you can get REM rebound. Okay, you mind, Drew, go ahead.
14-year-old female presents to the sleep clinic with complaints of hyperphagia, hypersomnolence, and sleep paralysis, leaden paralysis. She reports an upper sleepy scale of 21. Her mother notes she is not sleeping, just laying in bed like on a log. The patient reports taking Accutane nightly, phenelzine 60 in the morning. Sleep provider orders a PSG MSLT, which rules out sleep apnea, but shows MSL of 11. What is the next best step to manage? So for patient Accutane in the morning, phenelzine evening, start low dose Adderall, start with apnea. PSG MSLT.
Oh, hit him first, you say 14 years of age. The effort is 21, and is she driving a car? Is she-
I'm not familiar with what Accutane does to sleep. My inclination would be maybe. Yeah, I don't know, B, phenelzine, B.
Yeah, this is a tough question. You're right. I mean, so with the latent paralysis, that's characterized as heaviness in the limbs. This is atypical depression with hyperphagia, hypersomnolence. It gets confused with Klein-Lemmon syndrome. It's generally in teenagers, but what's interesting is they have this hyperphagia and hypersomnolence. But when you do PSG MSLTs on these patients, the mean sleep latency is usually 11. It's normal. So there's a term in psychiatry called clinophilia, and it's just lying in bed. So when this person has hypersomnolence, they are not sleeping, they're just lying in bed. I mean, there needs to be a different measure of objectively measuring hypersomnolence in these type of patients because the MSLTs come back normal. So usually it's the anhedonia or the depression that keeps them confined to bed. With this question, this is a very tricky one. The phenelzine is an MAO inhibitor, and I know that I just mentioned that they all increase norepinephrine, serotonin, and dopamine, but this is the only one that is sedating. For unclear reasons, so we should switch it to the evening, which might help. It might just be adding injury to insult. But typically, at therapeutic doses, phenelzine increases GABA and it inhibits the degradation of melatonin. These are the only FDA-approved MAOI inhibitors in the United States, but just remember that they're all activating with the exception of phenelzine at 60 milligrams. The only thing that I wanted to mention is that the higher the dose for all these, the more activating with the exception of phenelzine. Short question. Anybody, any takers? Sushil?
Yeah, sounds good. Which of the following medications is most likely to suppress REM sleep on a nocturnal PSG? Protriptyline, mirtazapine, trazodone, methazidone, and bupropion. So I believe, generally speaking, we talk more about serotonin agents being more likely to suppress REM. So I'm gonna say,
Keep it high. during sleep.
was that?
Yeah, keep it high during sleep.
Yeah, I'm gonna say B, mirtazapine.
That's a very good guess. So for unclear reasons, mirtazapine does not have any, and I'm not sure why, but it doesn't have any significant effect on REM sleep. I don't know if it's because of the norepinephrine. This is a very tough question. The answer actually is protriptyline, and a lot of times, you know, does this have any clinical significance? I mean, sometimes a patient will come to me and they'll say, I'm having abnormal dreams lately, and I'll look and I say, well, you're taking bupropion, it prolongs REM sleep. Maybe that might be the reason, but I don't know if that's accurate or not.
Yeah.
But so it's a tough question because I didn't put the doses here. But protriptyline is the answer, that it's most likely to suppress REM sleep. I did look into this a little bit, where the last clinical point where they said that some pulmonary specialists sometimes would use REM suppressing agents, because the mentality is that OSA is worse during REM sleep. So if you suppress REM sleep, you're lowering the AHI, but there are no reports of any drugs to use to treat sleep apnea by suppressing REM that I could find. Yeah.
People did use protriptyline because it's a non-sedating antidepressant to be able to say that's good for COPD, but they didn't really do it because they wanted to suppress apnea.
Makes sense.
That was in the seventies and
There is
eighties.
a New England Journal article, protriptyline.
Yeah, I think so.
Yeah. Back in the 80s, I think.
Any takers?
Sure, go get it. Loud, loud. Can't hear you.
A 36-year-old female presents to the street clinic with a chief complaint of insomnia. She reports, I feel all pumped up, full of energy to the point I can fall asleep. It takes hours sometimes for me to fall asleep. She reports her insomnia commenced about 2 months back. She reports taking no bath and multivitamin daily. She reports increasing her bath to 20 milligrams and
I can't pronounce it too well either. Vortioxetine.
40 to 40 milligrams about 3 months back on her own for she is a nurse and wants to play a role in her own treatment. She takes her medication at 8 p.m. and generally goes to bed at 10 p.m. What is the next best step in management? We order street legal. We inform her to take we inform her to give the back certified with bed. We inform her to switch her frequency of setting to in the past to keep her confident.
Can't even say it's Trintellix.
Yeah, that's
I've
it.
never seen it. So what do you think? Order a home sleep study.
Mhm.
30 minutes.
So this is a very tough question. It really is. This is a newer medication. It's classified as an atypical antidepressant. It inhibits the reuptake of serotonin, but it concomitantly blocks some postsynaptic serotonin receptors. To be honest with you, have only prescribed this twice because it's non-formulary at the VA. It's a very interesting medication. I just want to show you here, like it will inhibit the reuptake of serotonin, but it blocks 5-HT7, which is associated with circadian rhythms. It blocks 5-HT3 and it blocks 5-HT1D. But when you block 5-HT3, you get an increase of histamine, acetylcholine, norepinephrine, dopamine, and serotonin in the frontal cortex. So this is actually very interesting because, you know, what will end up happening is when you block 5-HT3, then you have more histamine, more norepinephrine, more dopamine. These are all wake promoting neurotransmitters. And if you really think about it, I mean, probably just, in my opinion, maybe orexin is the most potent wake promoting neuropeptide because that activates histamine, norepinephrine, dopamine, then maybe after that glutamate, and then maybe after that norepinephrine, but you know, that's based on conjecture. But so it increases norepinephrine, it increases dopamine. So I just want to say it's a very activating med, and the FDA approved dose is 20 milligrams, and this patient is taking 40. So generally you would want to take this medication in the morning. It's a newer medication. It's becoming more popular, but I think it's very interesting.
What's its indication again?
Major depressive disorder. It's used off-label for anxiety, but in the same breath, if somebody were to do that, they would really have to use a low dose of it because, you know, it would, you know. This is the last question. Kate, can you do it?
32-year-old female presents in sleep clinic for management of her nightmares. She reports being required to sleep alone secondary to a violent dream enactment. She tearfully reports, "I punched my husband twice in the past week. I do not remember doing it." Upon obtaining collateral information from her husband, you discover these episodes usually occur during the second half of the night. The patient's eyes are closed during the events. She has variable recall of her dreams. She notes her psychiatrist mentioned a diagnosis of RBD and requiring clonazepam. She is currently taking fluoxetine for depression and motion for back pain. What is the next step in management? I would ask about the Prozac before, or the sleep disruptions before the Prozac.
Yeah, this is a good answer. That's correct. I've actually seen this in the mental health clinic a few times, maybe in the past 8 years, maybe 4 times. Essentially, when we think of REM sleep behavioral disorder, we're thinking of a 55-year-old male with a neurodegenerative condition. Occasionally, I'll have a young female or a young male in their 20s or 30s come in and they'll mention that they're having this dream enactment, and then I'll look and see if they're taking a medication with a serotonergic focus. And if they are, if they can connect the dots and establish a temporal relationship, then I'll remove that medication and start bupropion. But in some cases, if I'm unclear, then you know we could order an in-lab PSG. This is the data that I found is that the prevalence of SSRI induced RBD is about 5%, and it's hard to distinguish between the two. There's some literature that in terms of antidepressant induced RBD compared to Parkinson's RBD, patients with antidepressant RBD on the sleep study, you'll see higher REM sleep without atonia in the anterior tibialis muscles. Whereas in patients with Parkinson's RBD, there's higher REM sleep without atonia during tonic REM. So this might be a way to delineate it, but of course you have to establish a temporal relationship. What we think is that when you agonize 5-HT1A, that increases muscle tone, and maybe that's the reason. But yeah, no, great job, everybody. It was interesting. I gave this talk to the primary care group, and they had they found a lot of the questions challenging, but I'm seeing that you guys did really well, and really appreciate you listening through.
You got something